Hello and welcome to our Infectious Disease podcast. Today's episode is the second in a three-part series on overcoming barriers to optimizing ART for people living with HIV. Today we try to overcome common misconceptions about who is a candidate for a switch in their ART. We're joined by Dr. Cristina Mussini from Italy and Dr. Brian Wood from Seattle. To follow along with the slides, visit the show notes for this episode. Now let's join the discussion with Dr. Mussini.
So, which are the reasons, at least for guidelines, to consider regimen optimization in setting of viral suppression? So, simplify a regimen by reducing pill burden and or dosing frequency, enhance tolerability and or decrease short and long-term toxicity, but also prevent or mitigate drug-drug interactions, eliminate food or fluid requirements, switch to a long-acting injectable regimen to relieve pill fatigue or decrease potential stigma or disclosure concerns associated with taking daily oral medication. And then allow optimal use of ART during pregnancy or when pregnancy is desired. And last but not least, to reduce the cost. So, which is our experience, Brian, about simplification to two-drug regimens, daily oral or long-acting injectables? Which are the candidates that we switch? Do we want to start?
Happy to share some thoughts, Cristina, and then very curious what your experience and strategies are too. Maybe we can start with the switch to two-drug oral ART. I will just share that I do prescribe a fair amount of dolutegravir lamivudine as a two-drug oral maintenance therapy. I like that combination as long as someone does not have hepatitis B and as long as they do not have known or suspected resistance to the components of that combination. I think it's really effective as a daily oral maintenance. For example, individuals who have been taking dolutegravir abacavir lamivudine, I think are excellent candidates because we can drop the abacavir and eliminate all the concerns and side effects. I have prescribed dolutegravir rilpivirine a handful of times. I don't like it quite as much because of the meal requirement, the PPI interaction, but I do have a few people on my panel taking it. So I like these options as long as someone does not have hepatitis B and does not have resistance to the components, but I favor dolutegravir lamivudine. I'm curious your take.
No, I have to say that I started prescribing dolutegravir lamivudine when dolutegravir lamivudine was not even in the mind because we started with the patient who had some toxicities related to tenofovir diproxyl fumarate. So we published like 3 years before they started to do dolutegravir lamivudine. So I think that I completely agree with you. Paying attention to chronic hepatitis B, but for the rest, and I too don't like very much dolutegravir rilpivirine, even if it's very well tolerated. But I don't like, on top of what you have already said, also the fact that they have a different half-life. So if someone is not taking it correctly, there's the risk of developing resistance to rilpivirine. So what about those who we want to switch to long-acting cabotegravir rilpivirine?
Yeah, it's a big question, but I appreciate your point. Sounds like you were well ahead of the curve with dolutegravir 3TC. For long-acting cab rilpivirine, I will share that my thinking about it and practice has really evolved. When it was first approved here in the United States, I was pretty strict about, really following the criteria used in the registrational trials. Individuals with long-term viral suppression, individuals who had a history of taking their oral meds, again, as long as they didn't have hepatitis B, didn't have resistance to the components of the regimen. And now that we've seen data, which I think we will talk about more, about potential benefits and success for people with detectable viral loads, my prioritization and my clinic's prioritization has shifted a bit to really focus on the people who need it most, people for whom oral ART just absolutely is not going to be successful for whatever reason. So my inclusion criteria in my brain has expanded over time, and I'd love to know what you think about that.
Yeah, I completely agree. I think that we started just prescribing long-acting cabotegravir rilpivirine to those who enter our ambulatory saying, I want the long-acting because I read about them, but I really think that, with the time, we are understanding that this, on top of people being like, feeling less stigma in having this injectable combination. But also, I think that this combination can really answer. Could be the answer to some medical need. Not only about exactly what you said. I'm thinking in proactively proposing it because I think that I won't have any problem about adherence. I will also, if someone has a very busy schedule, everyday schedule, not someone who is traveling, that could be more challenging. But for example, women who are caregivers for babies or older parents, it's very, very important. Also think about the concern of someone having to hide the pills every day at home because they have kids, they are worried about they take the pills. So I really think that we have to think out of the box and starting to think that long-acting is really the future of antiretroviral therapy, definitely.
Absolutely. I think that's very well said. I will just add one thing that comes up for me a lot in my clinic, even came up this week, is individuals ask about long-acting injectables. It's such a phenomenal and novel, game-changing idea. And then when I sit and talk about what it involves, visit to the clinic every 1 or 2 months, regular injections, really coming to the clinic much more frequently than it would be if taking an oral pill once a day, which you often can just be, 2 visits a year. Some people tell me, look, I'd rather just take my 1 or 2 pills at home, come in every 6 months. And for others, it is incredibly important to switch to the injectable to reduce pill burden, reduce stigma, eliminate the pill fatigue. I have so many reasons, as long as they can make it to the clinic regularly. And I really want to support that. I really want to engage them in that decision making. And for people for whom it is a real priority, I really want to try to support that. And I wonder if similar conversations come up for you.
No, it's the same, especially because I think that at the beginning, we thought that it would be very stressful for our clinic organization. And it is, so we were just, and I agree. I think that for people with HIV, really the slogan, one size doesn't fit all, is true. It depends. For example, I don't like the injection. So probably I would take the pill every day. But on the other hand, I'm not very good in with adherence. So I think that at the end, I could, trade some pain for not having to think about the pill. But we absolutely have to propose the treatment to people with HIV. It's because if we don't, there are so many people who are not so well informed. And I think that is our duty to make the proposal. Then
Absolutely.
they lose.
I think that's so true. And hopefully the future is people individualize and, choose the option that's going to be the most likely to have success. So approved uses of the oral 2-drug regimens, dolutegravir 3TC, which is lamivudine, or dolutegravir rilpivirine. So the indications per the approvals and package inserts are virologically suppressed on a stable regimen. It is specified for at least 6 months for dolutegravir rilpivirine. No history of treatment failure. For a switch to dolutegravir rilpivirine, no known resistance to the individual drug components, or no known or suspected resistance to any NNRTI or INSTI, which is integrase inhibitor. I'll add there, my thought process usually is, as long as the individual does not have known or suspected resistance to rilpivirine, I would consider it. For example, if there's a K103N mutation, rilpivirine should be fully active, but that requires a bit of review and consideration. For dolutegravir 3TC, no known resistance to the individual drug components, no known or suspected resistance to integrase inhibitors or to rilpivirine. Now, there is a bit of data showing dolutegravir 3TC may be effective in the setting of an M184V mutation. I can't say I have prescribed it in that clinical setting in my clinic, though if it were really the only option or the best option, I might consider it. Maybe, Cristina, later I can come back and ask you your thoughts on that. Do not use if chronic hepatitis B infection, I think, is a really key take-home message, because rilpivirine itself is not reliable long-term for hepatitis B treatment. The approved uses of long-acting cabotegravir rilpivirine, the intramuscular every 1 or 2 month injections as approved here in the United States. I believe, Cristina, correct me if I'm wrong, available as every 2 month injections in most parts of Europe, indicated based on the registrational trials if an individual has long-term stable virologic suppression, no history of treatment failure, no history of known or suspected NNRTI or integrase resistance. Now, there's growing experience with prescribing long-acting cabotegravir rilpivirine to select individuals with detectable viral loads. The IAS USA guidelines now note that this can be considered on a case-by-case basis when a person has a detectable viral load, especially if efforts in the past to help support adherence, help them remember to take ART every day have not been successful. They have a high risk of HIV disease progression, and their virus is susceptible to both cabotegravir and rilpivirine. Again, this can be considered on a case-by-case basis. We are offering that here in my clinic, again, with a lot of adherence support and a lot of efforts to help an individual succeed at coming to their regular injection visits. Cristina, let's turn to talking about some of the nuances here in terms of risk factors for virologic failure after switching to the long-acting injectables. What do you consider to be either risk factors or contraindications?
I really think that the evidence is there. We know that a single risk factor maybe doesn't have so much impact on the risk of virological failure. I would say all of them but resistance to rilpivirine. If you have resistance to rilpivirine, I don't think that you need any other risk factor. That's enough. While, for example, BMI, there are recent data showing that it's possible to prescribe long-acting also in obese patients, independently from the fact that you use longer needle or not. Other thing is that, once we accumulate data, we discover new findings. For example, we were really scared about A6 and A1. And I think that we will talk later that new evidence show that probably it's A6 that weighs more on the risk of failure. So I think that, what I do, I really look at resistance. And this sometimes is not easy because if especially people like MSM who are very, very informed, very convinced, and they really, want to start injectables, but maybe they have a long history of HIV infection. They change many regimens, and they have virological failure in the past. Maybe you don't have all the genotype. It's something that is tricky because it's difficult to say no. But on the other hand, the genetic barrier is lower, and I'm a little bit scared to prescribe it. If I have some doubt, I don't on the resistance, I don't prescribe. While the BMI or the genotype is okay. I don't know what you think.
Very much agree. And I'll just add, for me, the most important factors are no resistance to the medications, exactly as you said. And it can be tricky, and I think we'll get more into that. No hepatitis B and ability or willingness to come to regular injection visits, or in rare instances where a person absolutely needs it and has a lot of challenges getting to clinic, ability to bring the medication to them and do it regularly somewhere in the community outside of the office. But that's a more rare circumstance. But those are the biggest things for me. Exactly as you said, the subtype, the BMI, things like that give me much less pause. I think a really key take home here is BMI above 30 is not a contraindication. Like you said, Cristina, you need to prepare to use a longer needle, but it is definitely not a contraindication. I think that's been proven in multiple studies now. So I'll turn it to you for additional thoughts or to take over the next few slides.
Oh, yeah, I was just thinking that it's also a good opportunity for B vaccination, because in Italy it's mandatory to be vaccinated. But for example, for migrants, they come and they are not vaccinated. So while, with tenofovir, we have this pre-exposure prophylaxis when you have tenofovir in the regimen. But if you don't have tenofovir and you have drugs that are not active against hepatitis B, I think that you say, okay, we can start long-acting, but you have to undergo vaccination for hepatitis B. As I said, about the subtype, the evidence comes from, and also the BMI, but the subtype especially comes from the CARES START trial. I think that the CARES is a very important trial conducted in Africa, and showing not only that also long-acting are feasible in low and middle income countries, but also they gave us information about the subtype. So it's important to see that A1 is not a problem for the risk of failure, as you can see from the results that were really, really very, very important. And I have to say that the rate of suppression is so high that it's difficult to see in other trials such a high level of, because every time you switch, you have also to start a new contract with the person that you have in front of you. And sometimes the continuation arm perform much better than the switch arm. When it's not the case in this, it is even more, problematic because of the injection and whatever. So this is very important. So we said, and also in the CARE study, it has shown that the most important thing to look at is the previous resistance. But we are talking about people who have a suppressed viral load. So how can we check for previous resistance? What do you do?
So like you said, it can be tricky. I always prefer a history records of past ART regimens, past viral load results and virologic failures, and past traditional RNA genotype results. I always prefer that. And then if I see that and I see the resistance mutations, I plug them into the Stanford database. I look for resistance to cabotegravir or rilpivirine, or the UCSF Ward 86 team has a protocol available online, and they have done a great job cataloging resistance mutations that led to virologic failures in the trials. And I think that's a great resource too. I think the real challenge comes when you cannot get records. So if someone is on a first regimen, there's no concern about virologic failure, it is less challenging. If someone has taken multiple past regimens, now their viral load is suppressed, but they've taken past integrase inhibitors, elvitegravir or raltegravir, maybe some missed doses, or past, especially older NNRTIs, nevirapine, for example, and I cannot get records, that's the situation in which I consider an archive or DNA genotype to try to be sure there's no integrase or rilpivirine resistance. That's where it gets, I think, tricky. Cristina, what do you do?
Yeah, we do this, and we do also, I have to say, the archive DNA. We do it because for us it's easily accessible. I think that this, and I have to say that we have once a month a discussion of the cases with Carlo Federico Perno, who is a great virologist from Rome. He comes since 18 years in our clinic. So we have a peculiar situation. But I agree with you that in my ambulatory, the most important thing is the clinical records and the previous genotypes. Then on RNA. Then, as a cherry on the top, we look also at the DNA. And I think that it's, that it will be important to put together data also on the archive DNA. The problem is that, as you have shown, the risk of failure is very low. So to put together many patients to reach a statistical significance is very difficult. But still, I think that we don't know the meaning of archive DNA. We don't know if all the mutation, have the same weight. The Appleback mutation, how these are important. I think that we are not there. The most important thing, and is easily accessible, unless someone moved from another center without any documentation, but this is very rare, is to look at the chart, the clinical chart, the clinical records, and to look at the previous RNA.
Yeah, absolutely. I think the challenge is when you, despite a lot of efforts, just can't get those records for whatever reason. And I've certainly seen that come up. And I guess I would just
with you that is the most important thing is to see the resistance to antibiotics, because the rate of resistance to INS is very, 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 very low.
Absolutely. I think it's a great point. So I think we'll get into that a little more, and maybe I'll put this back to you to add a few more details. So you mentioned the DNA or archive genotype. You also mentioned it's not perfect. So big picture, not only for switching to injectables, just big picture, when do you tend to reach for that test in your practice?
I have to say that we do it for switching only if we decrease the genetic barrier. Because if we use dolutegravir TTC, no problem. But cabotegravir, rilpivirine, we probably because we have used it in 120 people, so not on 1,000 of people. I think that we need to find to reassure us, to be more confident. So that's why we started with, and also because I have to say that it's true, very few people fail, but sometimes they have risk factors, but unfortunately, sometimes they don't. One of my patients failed because of this. He never failed. He was perfect, like 24 BMI, subtype B, no risk, but he failed. So I think that looking at also the archive DNA, or to the DNA, can help us in the future to find some peculiarities that could help us interpreting these failure that for me, they make no sense. But
Christine, I'm curious one more thing. So what proportion of individuals switching to IM cabotegravir, I didn't say that very well. For what proportion of individuals switching to IM cabotegravir do you think would you say you send the proviral DNA genotype? I'm just curious.
We live above the virologist. So for us, that's why it's a very peculiar situation. Usually we do it, but if someone never failed, so sometimes we don't do it. It's not needed, but we have a sort of, pathway. You decided in your ambulatory, so you send the person to the group for long acting, and they do everything in, they do also the DNA. But it's, I know that it's not for everybody. It's not, we don't prescribe, and probably it's our fault, but while an oral treatment, I decide whatever I want in my ambulatory. For the long acting, there is a second evaluation. before switching to long-acting for the group for long-acting only.
I see. I would say, I would just add to that. I really like what you said about decreasing the barrier to resistance. For me, if I see someone who maybe is new to my clinic, they're not on a, first or even second line regimen, they're on multiple pills. It seems like a quote unquote salvage regimen, and I can't get records. I suspect there's resistance. And then there's really a reason to switch to not only a simpler regimen, but a regimen that decreases the barrier to resistance. Then I find it to be really useful. If I cannot get records, if I cannot get past RNA genotypes, there I find it to be really, really useful. So I tend to base it on my suspicion that there might be archived resistance that would affect my new regimen, especially if, like you said, the barrier to resistance will go down with the new regimen, whether it's to a lower barrier oral regimen or injectable. What are your thoughts there?
No, I completely agree. And also when it happened when we have these cases of prolonged low-level viremia, that you cannot amplify the RNA. You want to kill yourself as a doctor when you look at these values, the viral load, even if they are still below 200. And there has been the data at CROI confirming what we all thought, that they are just clones. So we should not worry. But since the person was always undetectable, and then at a certain point they started to have this low-level viremia, reassuring them and ourselves that nothing is going on also in the reservoir is something that could be useful.
That is such a challenging clinical scenario for the clinician and for the patient, the individual trying so hard to take the ART, but not seeing that undetectable viral load. I was talking with colleagues about a very challenging situation just like that this week in clinic. Probably a great topic for another module.
Yes.
For today, for time.
This is just to say that the result, as we said, of the DNA have to be interpreted with caution, because we don't know. There are mutations that are only really present in a very small proportion, and they don't have any clinical impact. Or someone that they are losing, for example. But it's difficult. I said that I'm in this very privileged situation that I have a very good virologist who is interpreting it. It's not something that I do myself. So I think that this is our probably last discussion. That is, but we have already covered some of it. So I would go non-NRTI resistance. Can you simplify to BF-TAF or dolutegravir plus the 2 NRTIs?
So I think we've learned a lot about that in recent years, and I think we've learned that the answer is yes. And I have done that in my clinic. Someone with a M184V or I mutation, even sometimes with thymidine analog mutations or TAMs in addition, especially if I anticipate they will take their oral ART reliably, they don't have a lot of challenges taking meds every day. Yes, I think that big TAF-FTC or dolutegravir plus 2 NRTIs, especially TAF-FTC or TDF-FTC, I'm not as big a fan of abacavir rilpivirine. I think yes, can be effective in that situation. Would you agree with that, Cristina?
Absolutely. And we know we always have put lamivudine because it's also very well tolerated. And I think that we thought maybe that lamivudine was, even because of the genetic barrier of 184V, we thought that it was not a strong drug, which is not true, because the data on dolutegravir monotherapy are not so well. While just adding lamivudine, it's very, very difficult that they fail. And so if we look at the data while we discuss, it's just, you see, also I think that the DHHS just say what we have said. So we have to check, we have to look at this. But also that, there is evidence of high resistance barrier with, I always said that dolutegravir and bictegravir, which is similar to dolutegravir as a structure, are like the pillars really of the, of their antiretroviral regimen. And we know that sometimes people with HIV take their oral regimen like 70% of the time. And despite this, they don't fail because they have very, very strong regimen. And the genetic barrier is so high that when they fail, they don't develop any resistance. So all the trials have shown that even if you have archived MN184V, the problem is not there for this. So great. I think that we had a very fruitful and a very nice discussion. And with that, I leave to you the conclusion.
I appreciate that a lot, Cristina. This was really great to have a back and forth, and I learned a lot from you, and I really appreciate it. Thank you so much for your time.
Thanks to our faculty, and many thanks to you, our listeners. To learn more about how to overcome barriers to ART, click on the link in the show notes.